Good morning, everyone. I'm Hiroki Hori from Japan, as introduced. I'm currently in the position of South Asia Continental President. In this session, I would like to talk about childhood cancer in Asia. Okay. Asia is the largest and the most populous continent. South Asia covers a total of 47 countries. These countries are located in the area of 4 WHO regional offices. Asia has also cultural, religious, and economical diversity. The health insurance system and health services are still developing in many low and middle income countries in this region. It's okay? Okay. I move on to the next. The Sub-President Guillermo presented. WHO is currently operating the Global Initiative for Childhood Cancer, GICC, in collaboration with SIOP and St. Jude Children's Research Hospital. To conduct WHO GICC activities effectively, we should know the baseline condition of childhood cancer practice in Asian countries. As a first step, Dr. Muhammad Sajil Khan, the co-chair of SIOP Global Health Network Committee, conducted a survey on childhood cancer in 2022. The number of participating countries were 42, as indicated in this slide. The National Pediatric Hematology and Oncology Societies were established in 22 out of 40 countries in Asia. National multicentric clinical trials were conducted in 11 countries, mainly in high and upper middle income countries. The expected number of children with newly diagnosed cancer in those countries were 123,000 per year. This slide showed estimated 5-year survival for diagnosed childhood cancer reported in Lancet Oncology in 2022. Countries colored with red and orange indicated those with less than 50% of 5-year survival. Those colors distribute in Asia and Africa. This graph indicated a correlation between annual governmental health care expenditure per capita and childhood cancer survival. The data are a little old, but it clearly indicates that childhood cancer survival is lower in low-income countries. Countries at the bottom of the graph are Asia and sub-Saharan African countries. These data are indicated that we need more effort to support low and middle-income countries in Asia. We have to take action for improvement of survival rate of children with cancer. The action should be directed at human resource development, stable logistics of medicine, and better clinical practice. But we should not forget some other challenge to be approached in those countries. There are considerable number of children with cancer who are not diagnosed correctly or are going to die without being diagnosed with cancer. Some have limited access to primary health sectors and pediatric cancer centers. In such situation, patients present at hospital with advanced condition of cancer. Treatment abandonment is also a serious social aspect of cancer treatment. Okay. This table, okay, wait. Up to this is slide number 8. Okay. This slide shows the frequency of treatment abandonment by country. The data are from the publication in 2015. Dark red color indicate higher rate of treatment abandonment. Many Asian countries face a problem of high treatment abandonment rate. This paper also indicates high variability of treatment abandonment rate in a single country. The data from China, India, and the Philippines are shown in this paper. For countries with huge land or many island areas, it seems difficult to improve the situation equally over the countries. Up to this point, I argued the general issues of pediatric oncology practice in Asia. Next, I would like to focus on acute lymphoblastic leukemia, one of the index cancer in WHO GICC, and the most common cancer in children. This slide shows the change of treatment outcome among children with ALL over the 40 years at the top children's cancer hospital in the US. The outcome has steadily improved with time. We may overlay the situation of our countries onto any of Kaplan-Meier curves in this graph. This table shows the treatment result from the selected clinical trials enrolling children with ALL in Asian countries, mainly high-income and upper-middle-income countries. Event-free survival rate range from 50 to 80%, while overall survival range from 60 to 90%. The results from high-income countries in Asia are compatible with those from the US. But, as I already mentioned, Asia has economical diversity. We should adapt the strategy of diagnosis and treatment to the situation of each country. In the paper which our colleagues published with other Asian hemato-oncologists for adults, we proposed 4 categories from basic resource to maximum resource, according to the situation of health service in each country. Treatment guidelines for low and middle income countries were published from different groups. In WHO GICC activities, we should support to create the guideline matching with the developmental stage of each country. In conclusion, we should expand well-organized clinical trials for childhood cancer across Asia, which lead to advancement in the clinical practice of pediatric cancer. SIOP is currently initiating a program for advanced the research capacity in low and middle income countries with support from Amazon and Foundation S, as Guillermo mentioned. Last year, the proposal from IMPOC and POEM were accepted for this program. I would like to suggest other clinical trial groups in Asia to apply to this program for further advancement of clinical practice. Thank you for your attention.